Good morning. Welcome to Chapter 18. Today we'll talk about the treatment of substance use disorder. First, remember that addiction does not care who you are. It doesn't matter how much money you have, how smart you are, the color of your skin, or anything else. Next, it's often the case where by the time individuals get to treatment that there's all sorts of other issues and consequences going on. It's rare that somebody comes to treatment and they don't have some sort of social consequence, legal consequence, loss of a job, co-occurring mental health disorder, or some other consequence related to substance use. So it's real important that when a person comes to treatment that we assess what their severity of addiction is and also what their other needs are. Are they in need of legal, medical, housing, food, and other support systems? Also, it's important to intervene as soon as possible before the disease progresses more and there are more social, economic, and other consequences. So, again, it's real important that we accurately assess and diagnose the individual so that we can create with the client a client-centered treatment plan that usually will go from least intensive treatment to most intensive treatment. Some individuals may be at a stage in their addiction where outpatient treatment is appropriate. Some individuals are very progressed in their disease and need a much more structured, intensive environment. And lastly, treatment is less expensive than incarcerating individuals. It just makes sense. It makes sense economically, socially, and from a public health perspective. We want healthy individuals that are contributing to society as opposed to individuals sitting behind bars, costing us money, not growing, not healing. When assessing individuals upon entry into treatment, we often use the ASI or Addiction Severity Index. This one looks at 6 domains, including alcohol and drug use, as well as legal, family, medical, and social status. This helps us to see what's going on with the client and how to prioritize those needs. Separate but related is Maslow's hierarchy of needs, and this one demonstrates from very concrete fundamental needs like food, water, shelter to more abstract needs like love and growth and acceptance. A graphical representation helps. Here at the bottom are those physiological needs, food, water, shelter. Then going from that to safety needs, and that includes physical safety like shelter as well as safety from physical harm. And then those more social abstract needs, love, respect, growth. So we need to assess if an individual is physically and psychologically stable upon entry into treatment. If it's obvious that the client is in need of medical detox, then we'll refer the client to an appropriate service for that. If it's obvious that the client is psychotic, then we'll refer to an appropriate service for that. So those two needs have to be met in order for a client to enter into treatment. And we want to address those basic fundamental needs, food, shelter, water. It's very hard for a person to concentrate on healing from addiction if they have no food, shelter, and water. So that's how we triage the situation. Also important is assessing the client's readiness for change. Where are they in the stages of change model? If you've taken theory yet, I'm sure you've come across Prochaska and DiClemente's trans-theoretical model, also known as stages of change. And this one looks at the different stages from pre-contemplation, where you're not thinking about change at all, to contemplation, well, maybe I might want to think about changing. Preparation, okay, I want to change, and these are the steps I'm going to take. Next is action. Okay, I'm taking the steps, and then maintenance. All right, I've taken these steps. Now I'm going to work at maintaining sobriety or whatever health behavior you've changed. Here's a picture, and I like this graphical representation because it's not a linear model where you go from step one, two, three, four, five. Absolutely. In the stages of change, it often happens where a client makes some really positive steps, but then has a slip up and has to regroup, step back, and start again. So it's important to know that stages of change, it's not linear and absolute in one direction, that it sometimes is a kind of a spiral where you step back and then move forward. Treatment providers use different strategies. This is not an exhaustive list by any means, but a sampling. So, cognitive behavioral therapy, or CBT, this is a pretty popular model right now. Here we're talking about changing your thoughts will in turn change your behaviors. Also, individual therapy as well as group therapy. Psychotherapy is referring to talk therapy, where you're talking to a clinician. Pharmacological therapy is the medication assisted treatment that we've been talking about, and we'll talk more about that at the end of this presentation. And many programs often combine different therapies. Right now and in the future, the name of the game is evidence-based interventions. These are interventions that have a lot of research behind them showing positive outcomes. So most grants and contracts out there will call for the use of evidence-based interventions. We want to use a strategy that we know will have positive outcomes. We want to get the most bang for our buck these days. And also important is Alcoholics Anonymous. So, Alcoholics Anonymous has been around for a long time. It's free, it's everywhere, it's offered in every city, all throughout the day and night. Clients can go and get support from their peers. This has been a really important tool in the recovery toolbox. A little bit about retention and relapse. Often and unfortunately, relapse is a part of recovery. Relapse is probably more common than not. And like we looked at in the stages of change model, we slip up, we fall down, and then we get back up again. And sometimes it takes people a few times, a few treatment episodes to actually maintain sobriety. Oftentimes, clients don't complete the treatment episode. This is also, unfortunately, more common than not. And most people who drop out will drop out within the first 30 days. So that's a real crucial time period, whereas providers, we want to really engage that client so that they feel motivated and part of and keep coming back. And relapse is like other chronic conditions such as hypertension, diabetes, it happens. This is a table that we developed in one of the programs that I worked with, and this is for the clinician and the client to look at red flags that may prevent the client from staying in treatment. So, first we have I don't have a problem. So, the client doesn't see themselves as having a problem. I don't belong here. I'm just here because the court said I have to be here. Next is I don't feel motivated. I just don't want to be here. Life keeps getting in the way. all of us have competing priorities where we have families, jobs, school, all kinds of things that want our attention, and coming to treatment just doesn't fit into my life. I don't have time for it. Where the truth is that people with the disease of addiction have to make recovery a priority, or else all the other things, employment, social relationships, legal problems, will not go well. Lastly, this is all I really know. Change is really hard, and oftentimes people, they're just not ready. They don't have the support. They don't have the support from their family, their friends, their community, and don't want to give up those friends or family members that are also using, and not changing your environment will work against your recovery. So, a few ideas about red flags for risk for treatment dropout. And if we see these red flags, we'll say, hey, this might be you. What can we do to help you to overcome this obstacle?